Okay, yeah. So today we are basically, like ma'am mentioned, we're going to talk about difficult conversations. Uh, so we are basically talking about how to break bad news, any kind of bad news, to families and to patients. We are also going to speak of collusion today. Yeah, many of us might have already heard this term of collusion. Uh, in case you haven't, just to refresh, collusion is basically when the family conspires among themselves or with professionals to withhold information or lie many a time, mostly to the patient itself. Yeah, so you might have met patients, oh sorry, you might have met families, caregivers who come and tell you that, please don't disclose the diagnosis to the patient because they might not be able to take it, or they'll break down, or they'll be very very scared and things like that. It's usually well intentioned, right? It's usually well intentioned, acting in what is believed to be the best interests of the patient, to protect the patient from emotional harm. However, what happens is this usually creates tension when the patient wants to know the truth, and the patient, as we already saw, has the right to information, right? It's not just about them wanting to know, it's their right to know the truth. And we need to address collusion, especially when it's hindering good quality care. It is leading to futile interventions because we haven't been talking about the prognosis, and we aren't being honest about what is actually realistically possible. And ultimately, because we are uh, getting into futile interventions, becoming harmful to the patient, right? And becoming harmful to the patient, not just uh, in the sense of their physical health, but also emotionally. Uh, because as you will see, most of the times patients do have an inkling, they do have an intuitive idea that something is not okay. Yeah. And then they also realize that people are hiding things from them. So that's also not a very good feeling to have in the first place. Um, so, yeah, that is basically what is collusion. Let's look at how to manage this. Yeah. Sangeet, next slide. Yeah. So, I've broken this down into steps so that it's easier for us to understand. So, if you're speaking of steps to manage collusion, firstly, when you start talk, we are not going to confront, we are not going to shout, or we are not going to lecture the family who is trying to collude, okay? Uh, because as we already spoke, it's a well intentioned effort from their side. So, we are going to convey to the relative that we are on their side, right? Don't start by trying to convert them. The approach should be, you want the best for, let's say, your mother. I too want the best for her, and let's talk about it and make plans. Right. So, first of all, make sure that they know you're on their team. That's the first thing. Secondly, then you explore the family's understanding, the family's insight about the illness, and what is their reasoning behind the collusion, right? Are they trying to protect themselves? Are they trying to protect the patient? Find out. Let's not assume. Yeah, always try and find out. Uh, Assumptions, many times they can be misassumptions. We are not mind readers, none of us are, right? So, firstly, establish whether they are trying to protect themselves or the patient. Recognize that they may have valid concerns about the patient's capabilities and past behavior patterns, which we might not be aware of, right? So, when somebody says that my mother won't be able to handle the news of my father's diagnosis, now that might be a very valid concern, right? Because we don't know uh, about her psychological strengths. We don't know how resilient she is. We don't know her past behavior patterns, whereas the family does know that. So make sure, and this is important information for you to gain when you are going to break the bad news. So uh, when you start exploring the family's understanding, you find out what are their reasons, what are their concerns, and identify whether they have a correct understanding of the clinical situation as well, right? So that's the first, like once you have made sure that um, you are on the same team, then you explore why are they doing what they're doing, right? Only after that you get into the reassurance and explanation from your side. Um, and I keep seeing that people, we don't realize how important these first two steps are, not just in collusion, but in any kind of clinical communication. People many a times skip the first two steps and they directly jump into reassuring or explanation, and that doesn't really work. Yeah, you need to have these two steps first. Only then, whatever you're doing in your third step of reassuring is going to have an effect, or like it's going to be effective in the way that you intend it to be. So when you start reassuring, first of all, we are not, uh, what I mean by reassurance is we are going to reassure them that we are not going to walk in and impose information on the patient. Okay, because see, many a times they fear and they start colluding because they feel we are going to drop a bombshell on the patient and they are not going to be able to take it. Right? Sakit, next slide. Yeah. So make sure that uh, you let them know that, I'm not going to walk in and just say that, oh, you have this. No, we're not going to do that. Secondly, mm, find out if the family has already felt the adverse effects of withholding information from the patient. Okay, so, and this is always more effective than us telling them that collusion is going to have adverse effects. Let them think about it and let them come up with, because they are going to face these adverse effects. Yeah. So find out whether the patient has been anxious. Are they in the bargaining phase, making unrealistic demands about treatment? So these things are definitely going to be challenges that the family is facing because of the collusion. So let them talk about that. You also explore how much withholding information has affected the communication and interaction within the family. I mean, just imagine, it need not be about a serious illness. Any kind of a secret in a family is definitely going to affect the communication. You're not going to be able to openly interact with the person who you're hiding things from. So find that out about how that has affected the family interaction patterns. And then you explain the consequences of keeping the diagnosis from the patient. Also based on what they have already told you when you have explored about the adverse effects of withholding. Mm, You also mention definitely that you recognize the patient's right to information if requested, because ultimately you want the betterment of the patient, right? So we all know that the patient has the right to information, which the relatives might not know, and we need to let them know, right? And then you offer to facilitate that conversation between the family and the patient if they find it too difficult to handle or if they don't know how to tell the patient, right? Uh, and we'll see how to do that. The facilitation part, how do we talk about it? That is what we're going to look into when we talk about breaking the bad news. And then if they're still unwilling, okay, let us say you've done all of this, you've explored their understanding, you have made sure they know you are on their team, you know their concerns, you have reassured them, you have also told them that the patient has the right to information if the patient wants to know. And then still, if they are saying that no, no, we don't want to, then you get what we call conditional permission, uh, which is basically to find out what the patient already knows. Okay, so you let them know that I won't go in and tell them, but I'll just go and find out what the patient already knows or what they think or they have assumed about their condition, right? Then the next step is, next slide, is sharing information as it becomes necessary. So you explore the patient's understanding and you assess their wishes for further information. Okay, so this is basically, like I said, let us say you get conditional permission. Yeah, to find out what the patient already knows. You enter the room, you're speaking to the patient now. You start exploring the patient's understanding about what is happening to them, and you assess their wishes for further information. Like I had mentioned yesterday, they have the right to know, uh, but they they don't have a duty to know. Yeah, that is what we had spoken about yesterday. So again, let's not assume the patient wants to know. Let's assess their wishes for further information. Once we have assessed that, then we again come back, talk to the family, inform the family members about the patient's wishes. Okay. And only then we start sharing information with the patient. Share it in digestible chunks, avoid information overload. Because we are, if it is something that the family had kept hidden from the patient, it's definitely not something easy to handle for the patient. So make sure you're doing it in small chunks, mm, in a way that's broken down into smaller steps where the patient gets enough time to process what you're telling. And make sure that you're informing the family members what you have discussed with the patient so that everybody is on the same page. Yeah, the family shouldn't be kept guessing about what the patient knows now and what the patient doesn't. And you definitely keep encouraging open communication between the family and the patient. And if the situation demands clarifications or explanations, always pitch in. Right, like you keep facilitating that conversation or the communication about these difficult issues between, like, amongst all the members of the family, including the caregivers and the patient. Yeah, I hope it's clear up till here. Are there any doubts? I've tried to break it down into simpler steps, but if there are any doubts, please do let me know. You can type in the chat box. uh, okay. Assuming things are clear, if at all there are doubts, you please let me know by the end of the session. If we are to share information in chunks, it means may require multiple consults. Uh, yes, I mean, it's not, see, when we're talking about breaking the bad news, we're talking about serious discussions. It is, anyways, even if you give them all the information at once, um, it is not going to happen in just one session. It is going to take you multiple consultations. For them to process, for them to come up with doubts. Uh, there will be a lot of back and forth. They'll keep jumping from. We are also going to see stages of grief. So you'll see that people start accepting, and then again they use. You feel like, okay, the patient has started understanding, but then they again in the next consultation have jumped back to denial. That can also happen. So it will require multiple efforts and multiple instances of explaining the same thing probably again and again on your part also. Any other doubts? Okay, let's move on, and if there are any doubts we can look at it later. So this was Sangeet, the previous slide. Okay. Mm, so this was what we saw about collusion when it happens. Like typically this is what happens, that the family is colluding and they're keeping things from the patient. But rarely there are also instances where the patients will collude with the professionals to withhold information from their family. Okay, so let us say the son is your patient and he's telling you, please don't tell my mother, right? That is also collusion. This is more difficult because, see, the patient has the right to information, but when you're giving information about the patient to the family, the patient has to give permission for a disclosure of information. Yeah. So that's a little tricky and that will require a little more um, mm, time and effort from your side when it comes to talking to the patient about why it's important to let the family know. But the principles are the same basically. Yeah. Same as what we looked at until now, which is sensitive handling, exploration of reasoning, explanation about the consequences, and reassurance and offer of facilitation. That is what we're going to do in that same sequence, right? Uh, okay, so that was about collusion, and now we get to communicating the bad news. Okay, first of all, no one likes having these conversations, right? Let's just accept that. They are difficult, they are uncomfortable, and today we're going to see how we can make them a little less difficult and try and understand how our patients can react to these when we break the bad news, and how can we respond in these situations. No one likes to be the one to deliver bad news, but it's also helpful to remember our aim in doing it. We are giving somebody a bad news, true, but we are doing it in the best possible way so that it facilitates understanding of the situation. That itself helps people prepare themselves mentally for what is to come and not receive a shock. And at the same time, they feel supported in their emotional response to the news because of the way we communicate it, which is why we are having this session in the first place. And if you remember the 7 steps which we had discussed in the last session, uh, towards the end of the last session, are going to be very important as a general structure or a general framework for us to proceed. All right. So let's just quickly review those steps. Uh, the first thing was to build a relationship. Second was to open the discussion, then gather information, understand the patient's perspective, share information, arrive at agreement on problems and plans, and close the discussion sensitively. That was what we had discussed in the last session, right? Hello? Is someone?
No, nothing, ma'am. Nothing.
Okay, yeah. Okay, all right. So, so now, what the steps that we had discussed last time. This time we are going to see these steps being repeated to an extent in the protocols that will be touching upon. And well, before I get into it, some of you might be wondering, do we really have to do this? Why is it important? Why do we have to learn to do it? Because sadly enough, in our professions, we have to do it quite frequently. So if we anyways have to do something stressful, why not be skilled at it, right? Rather than fumbling around and making it more stressful for all of us involved. Um, so that's one of the reasons why we need to learn about this. Secondly, your patients want the truth. Thirdly, there are, of course, ethical and legal obligations to let the patient know. And most importantly, how we do this will affect the patient's comprehension, their satisfaction with medical care, their level of hopefulness, and of course, subsequently, their psychological adjustment. Yeah. You remember my patient from last session. Not knowing made her anxious and distressed and unhappy with her doctors. Knowing made things easier. Yeah. Now, again, just like there are barriers to communication, which we saw in the last session, of course, there are barriers to this difficult task of breaking the bad news. First and foremost, the one who is doing this is mostly stressed. Very obvious. If I ask one of you that you have to go tell a patient that we cannot offer any curative treatment, and that their disease has reached a highly advanced stage and is progressing, how would you feel? Nobody likes to say these things to their patients. And studies show that the bearer of bad news experiences strong emotions like anxiety. It's a burden. And this stress makes us reluctant to break the news, especially if the patient is already in a not so good condition emotionally. Nobody wants to do it. And it's not just how it affects our patients, it's also about how it affects us. And secondly, we might feel unskilled in certain areas, like how do I handle the emotional outburst? How do I do this without taking away hope? What if I'm looked at negatively because I gave the news? So all these uh, doubts and thoughts that come up. And again, as a consequence, if we are uncomfortable in delivering bad news, chances are we may avoid discussing some points which might be distressing to the patient. Or in the bargain of giving hope, we might end up giving false hope and optimism. So, having a strategy definitely makes things easier. It eases off stress from our shoulders as well, lessening the chance of a burnout for all of us. So, we are learning about this as much for us as for our patients. Okay, next slide. Yeah, let's just go a little back in time, way back to the 1950s, 60s, and 70s. Uh, at that time, doctors actually considered it inhuman and damaging to the patient to disclose bad news, right? Of course, that was also a time when treatment prospects for illnesses like cancer were quite bleak. But by the time we reached late 1970s, most physicians had become more open to telling the diagnosis to the patient. But now, patients were not really satisfied with that much. They had more questions. They wanted additional information. They wanted to know the prognosis. They wanted to know the side effects. They wanted to know how much time they realistically had in hand to live. Over the years, many studies in different parts of the world repeatedly showed the same thing, that patients wished to know. And then came issues of patient consent and patient autonomy, which gave a further push to openly communicating with the patient about the illness. But of course, the medical fraternity had to take into account that simply disclosing the truth without a concern for the sensitivity with which it had to be done, or neglecting the duty to support the patients through this and to help them take important decisions could have quite a negative impact on the patient, right? So we couldn't just overcompensate for years of hiding the truth with sudden insensitive truth telling. So then people working in the field have over the years tried to come up with protocols that we can train in and can follow in situations where they are required. Most of them are based on the underlying principle before you tell, ask, which is what we have been uh, seeing right from the last session, right? We always ask, we always explore, and only then do we tell. All right, so this is how we come to the year 2000 when we had spikes. Okay, next slide. Okay, yeah. Oh, sorry, just a second. Some issue from my side in the slides. Okay, so basically, mm, regardless of whether we are looking at spikes or whether we are looking at any other protocol like breaking the bad news, um, the main objectives of why we are doing this is are the same. We share information with the patient to gather responses from them to provide vital support which is required and creating a plan to move forward, right? So let's look at these protocols, um, and then we can discuss any doubts if there are in the protocols. Next slide. Yeah. So we have spikes here. As I said, spikes came in 2000, first proposed by Bailey and colleagues in the context of cancer. This is one of the most well-known protocols. You might already be aware of it. It's a six step structure which can aid in delivering bad news to patients and families. Mm, And let's look at it one by one. Next slide. Yeah. So the first S is uh, setting. Yeah. The setting up the interview when you're going to break the bad news. Make sure you're doing it in a quiet, private space. If arranging a room is not possible, at the minimum, we can at least make sure that the curtains around the bed are drawn. Don't do it standing somewhere in the lobby or in the corridors. Try and minimize distractions. Keep your phone on silent. Or if you're likely to get calls, let the patient know beforehand that there are chances you'll get calls in between. Involve significant others and let the patient choose who they want with them. Do they want the entire family? Do they want specific people to be there? So let the patient let you know. And when everyone is gathered, firstly sit down. Yeah, this just make everyone as comfortable as possible. It also, so when you're taking the time to sit down with the patient and the family, it also lets them know that you're not rushing through this. You're giving it the time and space that it deserves. So that is the S part of it, the setting. Yeah. Then we move on to P, which is perception of condition or the seriousness of the condition. Next slide. Yeah. So assessing patient perception. That's the second step, where you determine what the patient knows about the medical condition. What do they suspect? Make use of open-ended questions like we discussed last time. Uh, for example, what do you know about your condition? What has the doctor told you so far? If there are multiple doctors in the team. Uh, my experience is most patients, especially in advanced stages of the disease, are well aware of what's happening intuitively. So listen to their level of comprehension. If at all there is denial in the form of wishful thinking or unrealistic expectations of treatment outcomes, accept, do not confront at this stage. Just listen to what they're telling you. Uh, and then, uh, next slide. Yeah. So the third, the I is invitation. Yeah, obtaining patient's invitation. Ask the patient if they wish to know the details of the condition or treatment. Not everyone will want to know, especially those who are scared can resort to the defense mechanism of shunning information because it helps them cope. So always ask if they want to know, and if they say no, accept the right to not know also, but at the same time, don't close doors. Yeah, so make sure that you're letting them know that you will give them the offer to answer questions later if they wish to know. Yeah, it's not a now or never, like I said. And so even so, don't just ask, do you want to know? Make sure you are asking, like you're going a step further and asking them how much they want to know. So, do you want to know in detail? Do you just want an overview? Um, and do you want to spend more time in discussing the treatment options rather than the test results? So, all these things you need to clarify with the patient, get the patient's invitation to share information, and only then share what you know. The next is K, which is knowledge. Next slide, Sandeep. Yeah. So if the patient so you've obtained information, okay, let's say from the patient, and the patient has said yes, tell me. Firstly, always give a warning that it's a bad news. Okay, you could say something like, sorry, but I have a bad news to share with you. Mm, Again, when you're sharing, when you're giving away medical facts, use simple non-technical language which matches the patient's comprehension and vocabulary. Um, so uh, And again, so when I say use simple language, that doesn't mean that, let us say, your patient is a doctor himself, and you start explaining them in a very, very simple terms. Now, that's not going to be okay either. So consider the educational level, the socio-cultural background, um, so all these things, along with their current emotional state, age, and all of that. And only then, based on that, you decide how you're going to tell them. Give information in small chunks and periodically keep checking whether your patient has understood. Don't be blunt in the way you're speaking and respond to their reactions as they occur. Okay, so it's not going to be, so even if we are looking at it as steps, there is, of course, going to be an overlap. So keep responding to the patient's reactions, emotional reactions, and responses as they occur. And give any positive aspects first. Okay, whenever you're talking about the bad news, and only then go to the negative aspects. Make sure that you're giving away only accurate facts about the treatment options, the prognosis, and the cost. Yeah. Because there is, I mean, it's a human tendency to want to reassure, to want to give hope, but false hope is going to be more harmful in the long run. So make sure you're giving only accurate facts. And if you don't know about something, say that you don't know about it. But now, okay, this is something that many of you might have this question in mind, that uh, how do we tell that we cannot do anything for you? It's very important that you never say that. Never say there is nothing more we can do for you, because there is always something you can do for them. Yeah, you can keep them as comfortable as possible. There is always something you can do for them in terms of psychosocial, emotional support, in terms of pain, in terms of symptom management. Okay, you might not be able to give them a cure, but there is always something you will be able to do for the patient. Um, Next slide. Okay. Uh, then is the E, which is exploring emotions and addressing them with empathy. Like I already said, these are not actually stages occurring one after the other, right? There is an overlap. So as you gather and then give information, throughout, you will simultaneously be taking in emotional cues as well, identifying their feelings as they are expressed. There can be a range of emotions. You would see silence, despair, disbelief, shock, denial, anger, so many emotions that are possibly going to be there. First of all, give the patient time to express their feelings and then respond empathetically. Don't prematurely try to calm them down. Okay, let's say my patient is crying. Uh, it's best that I let them cry it out. Uh, and offer your support and solidarity throughout through reflective statements, empathetic statements. So, let's say, for example, I could say something like, I wish the reports were better, but we'll do our best to keep you as comfortable as we can. You're not alone, we're always here with you. Yeah. So, that kind of empathetic statements is what I'm talking about. So make sure these statements let them know that you've understood their emotional state. Okay. Um, and now there are chances that there is no expression of emotions. Uh, and that's again a defense mechanism where your patient does not want to lose control and start crying in front of you. So they might just have a very blank face. Uh, so in that case, you would have to ask exploratory questions and coax the emotions out a little bit and give them time basically to just process and let them feel what they're feeling. So here you can see on the slide also that I've given an example of, let's say, for example, my patient just blankly says, oh, so I guess I have to take more chemo now again. And then you can respond to it with something like what I've given below, that I can see that it's upsetting news. I know you were hoping to go home this week. Yeah, and maybe that will lead to them expressing their emotions. But that doesn't mean we are going to force them to do it in the first time itself. Like somebody said when we were speaking about collusion, it is going to take repeated attempts. It is going to take multiple sessions uh, for all of this to be completed. And then we have strategy and summary. Next slide. Yeah. So, which is basically having a clear future plan. Why are we going to have a clear future plan? Because definitely it's going to reduce uncertainty and anxiety. So once the patient has relatively calmed down, ask them if they would want to know and if they're ready to discuss the possible plans of action. Again, respecting their wishes. If they do not feel up to it immediately after they've received the news, it's okay. You can allow them time to calm down and you can always come back later. So, and let them know that you will come back later. And when you're closing the interview, ensure that you summarize the key points and inquire if they need clarification again. So that is the spikes protocol. Yeah. Uh, there are also a couple of others, but we shall only look at two of these. There is spikes and then there is breaks. Okay, the next one. Sangeet, next slide. Okay. So breaks was put forth by Indian and Nepali professionals 10 years later, in 2010. Uh, and this was published in the Indian Journal of Palliative Care. It is available online with open access. So is spikes. If you all wish to read up the original papers and want to know more about it, I can share both these papers with you. I mean, I can share it with Sangeet and then he can pass it on. Mm, and both the papers, the breaks one as well as the spikes one, have wonderfully explained the protocol, so you can definitely keep them as references. Breaks is again an acronym just like spikes, and that stands for background, rapport, exploring, announcing, kindling, and summarizing. Okay, we'll again look at it step by step. Next slide. Okay, so background is basically knowing the context of the patient. What kind of a cultural, social milieu is the patient a part of? Their religious, financial, educational background, their coping styles. Basically, it's not enough to know the disease status of a patient before breaking the bad news. You need to have done your homework about whom are you giving the news to. Yes. So that is why we need to know the background so that you're better informed, also more sensitive and you're more respectful towards the patient. At this preparatory stage, you also ensure that the physical setup is proper for the conversation, just like we spoke in setting in spikes. So removing distractions, having sufficient time, making everybody sit, all of that. So that's about your first step. That's background. The next is rapport. Sangeet, next slide. Yeah. Rapport is going to be very important in determining how your patient is receiving the news. Having a good rapport with the clinician would definitely make the patient supported, feel less isolated in the face of the news. Uh, and to do this, make sure that you don't hurry, don't rush to tell. Ask open questions and pay attention to verbal and non-verbal cues that you are receiving and respond to those cues. Next slide. Yeah. Third thing is to explore. Okay, exploring what the patient knows about the condition. You can see that there is a lot of similarity between both the protocols because ultimately they are both based on the same principles of communication that we spoke about last time. So, when I say explore, take your time to explore their concerns in detail. For example, if a patient is expressing fear or uncertainty while speaking of what they know, don't jump in to reassure. Explore the causes behind the fear and let them open up and share freely. Uh, because we might assume uh, some reasons, and the reasons might be something completely different about why are they fearing what they're fearing. So it's always better to explore first about what they know and the meaning that they attach uh, to the knowledge that they have. And after that is done, you announce. Next slide. Yeah. So after that, after you have had you once you have a rapport with the patient and the family, only then you announce. And just like in spikes, you do it with a warning to prepare the patient. Okay, always warn them that what you're going to say is not good news. Keep the explanation short, keep it easy. Don't get into elaborate, overly detailed, one sided information giving because they're not going to be in a state to take it all in. Be straightforward about it. Short, simple, easy. Okay. Uh, like I mentioned on the slide also, avoid jargon, avoid lengthy monologue, stories of other patients. No, very short, very easily comprehensible sentences. Regardless of the patient's education or cognitive capacity or whatever, uh, because when they're emotionally overwhelmed, it is not going to be easy to process all that you see. Next slide. Yeah, so this is followed by kindling of emotions, where again, you need to give adequate time for expressing feelings. Let them cry, let them take it out. Do not lecture or try to give false hope. Most of the times, this is a very selfish action, I feel. We start giving hope because we are uncomfortable facing the pain and sorrow of the patient. So we shut them down. And that's very unfair and honestly very wrong on our parts. So let them feel what they're feeling. Patient might at this stage ask questions. Make sure your answers are on point. Again, no elaborate stories of other patients and stuff. Very to the point, truthful, and share gently. Okay, so even if it's the answers are something that they won't like, you're still going to tell them the truth, but you're going to do it gently and with warning that they are not going to like the answer. Uh, there is also a chance of differential listening happening at this stage. Okay, which is something we already somebody had come up with this yesterday, right? Uh, so there is definitely a chance of differential listening happening where patient will selectively pay attention to what they want to hear. So be aware and alert to that possibility and keep checking for understanding. Okay, so that you know before you address it, you know, okay, my patient has only selectively paid attention to a chunk of information and not the other part. So then you can reiterate that other part. But for you to know that, you'll have to keep checking for understanding periodically. Like ma'am had also mentioned yesterday, ask them to repeat what they understood, and then you'll know. And then finally, summarize. Next slide. Okay. If possible, give the summary in writing because it's going to be difficult to remember everything in an emotionally overwhelmed state. Summarize all the key points, all the possible courses of action. Let them know that you're available for them if they want to share, talk, or ask anything, and fix a review. Okay. Um, don't leave them hanging. Always fix a review because you'll definitely you'll want to know how your patient is doing after receiving the bad news, right? So um, that is what you do, and most importantly, ensure immediate patient safety. Has the patient come alone? I mean, in an outpatient setting, are they driving back? Do they have someone at home who can support them? So it's not like bata diya chale gaye, like we have told and now our duty is done. That's not going to work. Uh, Now, some of you might be thinking, ki, that's all okay. I know the sequence of actions, but what do I actually say? Um, and we might go blank regarding that when the time comes. So it always helps to do a mental rehearsal, first of all, at least initially when you start breaking bad news. Um, Next slide. Yeah. Uh, and also this slide, which you see right now, is what it would look like in practicality. So let's say, for example, you would say something like, "Can you tell?" Like you have said to the physical setting, you're sitting, everybody's sitting, and then you're now asking about it. You'd say something like, "Can you tell me what you already know about your disease?" Let's say my patient knows that it's an advanced form of cancer. Okay. Uh, so then, and they've told you that, and then you say yes, and unfortunately, it's progressing. Now, this is what I mean by small chunks. Okay. So when you say that it's progressing, now that's a chunk of major information you've given them. So you pause. You don't rush and tell them everything else. Okay. So you pause, you take in cues. Of course, there are going to be emotional responses. Be there with them. through that, and only then you share the next chunk of information, the next bite, where that at this stage we're not able to offer a cure. And then you again, like I said, that's another major bite of information. So you take a pause there and see what's happening. And only then you move on to, okay, here are some possible options that you can choose from. Can I tell you about them? And if my patient wants to know, I'll go further. If they do not, then I won't. But I'll let them know that we will talk about it later. Okay. So based on the response, I'll proceed, and I'll definitely let them know that we are always here for you. Okay. Uh, Next slide. Okay. Now, regardless of how well we do this, however well communicated, let's say we follow these protocols to the T, bad news is still going to be bad. Yeah. So, I mean, it's not that I follow this protocol and my patient is going to understand and say it's okay. We will need to expect certain possible intense emotional reactions from our patients, regardless of how well we communicated the bad news, so that we can respond appropriately. The first person to try and talk about this process of grieving and adjusting to bad news and upcoming consequences of the bad news was Elizabeth Kubler-Ross. Many of you might be familiar with her work on stages of grief, which you can see on the slide here. Yeah, there's denial, anger, bargaining, depression, and acceptance. Now, although for ease of understanding and classification, we put it like this into clear-cut stages, we need to understand that these stages are not linear. It's not that, okay, pehle denial hoga, there will be denial first, followed by anger, followed by bargaining, followed by depression. No, that's not how it's going to work. They don't happen necessarily one after the other. They are very fluid. Okay, they can happen back and forth. However, there will be jumps, there will be skipping certain steps. All of that can happen. And they're descriptive, not prescriptive. Okay, what I mean by that is she was only attempting to clearly describe what can happen. She was not prescribing that the patient should move from one stage to the next in a rigid set manner. Uh, she was also not implying that everything other than acceptance is undesirable. So it's not that, okay, there is denial, anger, bargaining, depression, and finally we reach the stage of acceptance, which is our end goal. No, that is not how it works. Because each of these behaviors does serve a purpose and function to keep the person safe psychologically at that stage. So these emotional reactions are needed for us to process the bad news adequately. Okay, so let's look at them. So let's see what are these non-linear behaviors I've been talking about one by one. Okay, next one, next slide. Okay, right. So the first thing, denial, often the first reaction to bad news. What do I mean by denial? My patient is saying this can't happen, you are lying, the tests must be faulty, I want to take another opinion from a more qualified doctor. All these things are basically denial. And this is your patients trying to shield themselves from considering an upsetting reality. They often reject the news or they simply avoid the topic altogether. Yeah, it's shock absorber. A certain period of denial is quite normal, especially in the context of terminal illness. And this could actually be quite important to process carry information without facing it in conscious awareness. So it's okay to have a small period of denial, but we need to address it when it turns problematic. How do we identify that? Denial is problematic when it starts interfering with treatment compliance, when it delays treatment, where urgency is required, where there is symptom minimization, and where there is an insistence on curative treatment when curative treatment has been proven futile. That is when we definitely need to start addressing denial proactively. How do we assess this? How do we assess a denial? Mm, Listen to the words and observe the nonverbal cues. You'll find a discrepancy between them. That is when you know that it's denial. Next slide. Okay. So, so you'll maybe see the patient being very dismissive about it and saying that, oh, it doesn't matter and stuff. But if you look at the non-verbal cues, you will see that, oh no, that doesn't really match to what my patient is saying, or the casual attitude that they are presenting on the face of it. So this discrepancy is what is going to tell you that there is a strong denial happening. And how do you manage that denial? Firstly, ensure that denial is not due to lack of information or understanding. Okay, that is what I mean by how do you assess denial. So let us say my patient doesn't know about the seriousness of it, and they're really casual about it because they don't know that it's going to be serious. They don't know that it's a terminal illness or what it means to have a terminal illness. You won't find any discrepancy. The non-verbal cues and the verbal cues are going to be the same. But in case of denial, denial is not the lack of information or the lack of understanding. The patient has understood what has happened, but they don't want to face it. That is what is denial, right? So firstly, ensure that what you see as denial is not basically due to lack of information or understanding. You also check benefits and risks of denial to the patient. Okay, why are they denying it? Is the denial advantageous to them in some way? And is it risky? And in what ways? If the denial signals fear, for example, you see minimization of symptoms, you provide emotional support, you address the fear behind the denial, you don't address the denial directly. Don't confront directly because it's counterproductive. It's not going to help in any way. And emphasize your continued support, which will help the patient to ultimately, slowly, with your support, face the reality. Next is anger. Next slide. Okay. Now, anger commonly expressed by patients as they accept the bad news as reality. Okay. Now, the anger could be turned inward or outward. It could be in the form of blaming the doctors, the family, God, or it can also be undirected to a specific target and only coming out as short temper, less patience, more irritability, etc. When we are able to recognize it as a natural response, we can then be able to not take things personally. Let's say my patient is saying something hurtful, and I know that it's not about me, right? The anger is not about me. The anger is a natural response to a very bad news. So then we'll be able to tolerate seemingly hurtful accusations and even be compassionate in the face of it. And that is what our patients need. Always remember that anger is the tip of the iceberg. Okay, it's a secondary emotion. And what I mean by that is it indicates underlying so many things: underlying helplessness, underlying fear, underlying guilt, underlying the primary emotion is what's going to be the underlying emotion here. And what you see outwardly is the anger. So always remember that what you're seeing is the tip of the iceberg, and you need to explore where that anger is coming from. Mm, and so it could either be that the anger is because of another primary underlying emotion, or it could be due to ineffective communication between the patient family and the doctors, which we need to rectify definitely. How do you manage anger? Next slide. Be direct and simple. Okay, don't avoid the, I mean, if the patient is angry at you, it's okay. I mean, you need to still be direct and simple and truthful. Ask the patient to sit down, acknowledge, and name their emotion and address their need to be understood. Okay, if we are aggressive in the face of their aggression, that's definitely not going to help anyone. So acknowledge that they're angry. Okay. So what I mean by acknowledging, naming, and addressing is something I have put it up on the slide also, that I say something like, I can see that you're angry. Can we sit down and talk? And I shall try my best to help. And always recognize that the anger is at the situation, not at you, regardless of the words that the patient is using. And be calm, be empathetic, have a positive body language. And this is possible when you start recognizing that the anger is not at you, the anger is at the situation. Give them time to express their anger. Don't jump into justifications, explanations, all of that. Keep observing their nonverbal cues because that will give you um, a hint about what's the primary underlying emotion there, and acknowledge reasons for being angry. Okay. Let's say, for example, somebody's reason could just be that it's really unfair that, you might have seen these kinds of patients where, let's say, a patient has lung cancer and they keep telling you that, I haven't, I mean, see that other person. I know people who have been smoking for years. I haven't touched a cigarette and yet here I am. And they are happy going about their own work and they're angry about it. And that's absolutely right. So acknowledge the reasons for anger. Next slide. What can worsen anger? If we are defensive about, how we are right and how, if we see, if we assume that the anger is at us and that it's an attack on the treating team, we are automatically going to become defensive, and that's going to worsen the anger of the patient. So being defensive will worsen the anger. Indifference will definitely worsen anger. Having a dismissive attitude, blaming the patient that, oh, this is, you've come to this because you didn't follow what we had told you and stuff. That's definitely going to worsen anger. And blocking the patient, where you leave them feeling unheard. Um, and premature reassurance is a way of blocking the patient. Okay, so you don't allow them to say anything, and you just jump into reassuring them and saying that it's going to be okay and you'll try your best and all of that. You are still leaving them feeling unheard, and that can make the patient more angry. So let's not block the patient. Let's give them time to feel angry or feel whatever emotion that they want to feel at that point. Okay, so that's about anger. Uh, Next slide. Then there's bargaining. Now, is basically when patients try to have some amount of control over their condition. Okay, they start negotiating about treatment adherence or accepting help from others, or even something like if they feel guilty about something. And let's say my patient feels guilty about not being a very good husband. Okay, and he says that, oh, I treated my wife badly. God, I promise I'll be a better husband if you cure me. That's bargaining. Okay. You don't need to repeatedly correct bargaining, but let's also not participate actively in it, as that can be misleading about how much is actually in your or the patient's hands. So don't participate actively in that bargain. Um, then comes depression, very obvious, most easily recognizable, and probably the previous stages, the previous behaviors are an unconscious effort to protect the patient from the emotional pain in the stage of depression. Um, Now, dealing with depression is something I think your psychosocial aspects of palliative care will definitely cover. Uh, and then lastly, we reach acceptance, where the patient is recognizing the reality of the diagnosis. They are not struggling against it, and they're focusing on living the most in the time left and preparing mentally as well as practically to say goodbye, focusing on adding life to their days rather than adding days to their life. Mm, I would like to end the presentation with a little quote. Uh, Sangeet, next slide. And I think this is basically why we have had these two sessions, is because we cannot change the outcome, but we can definitely affect the journey. And I think based on what we have discussed in the last two sessions, and if we start applying it, will definitely affect the journey for the better. Yeah. Any questions? I think there's also a case discussion today. I hope I haven't rushed through the presentation. If there are any doubts, please let me know, or else we can get to the case discussion.
Thank you, Mukta, for taking us so well in a methodical way.
Thank you, ma'am.
There was like I just thought of adding on just couple of things. They were asking, isn't it, for more number of sessions and things. For that, we have to. It will take one session may not be enough for any of these situations, breaking bad news or collusion or even any form of communication things, because these are sensitive and specific issues. So that only one thing what I thought of adding is sometimes what happens, the same information we may have to be giving many times. For example, in those situations, you can find out who is the next of kin. For example, this patient or person has 5 siblings. 5 times you need not be telling. Okay, so what you can do from that point of view is find out from the patient or family, whoever it is, one person next of kin. Next of kin means, by that what I mean is, who is the person closest and considered the best person by the patient and the caregiver. Give all information to them, and then ask them to convey it to the rest of the family. Or whenever you're meeting, ask, like we always say, like set up, no? You get a place where not 1 or 2 people. If you have a facility for a room and thing, where few people can come and you can tell everything in one way, in one time. And then one more thing is that, which I or all of us used to do, is we have to tell the patient, because these are all lifetime issues. See, breaking bad news is something not good from the patient point of view also. So we have to tell them, even if they come up, you set up a meeting to tell all that, we will tell them, you may not have come up with all your queries. When you go home, some more queries will come up. So we generally tell them, you can come back, when you go home, and either queries in what we have spoken or new things may crop up. So in those situations, feel free to come back. So one meeting as such for all these will not be sufficient. So 2 or 3 will be needed, and that 2 or 3 increasing to more depends on the intensity and the state of the patient. See, sometimes very educated, you may need more meeting. Sometimes not educated at all, maybe education and general awareness of things and things. No, they are totally, it helps. One helps the other, but it can be the other way around also. Because none of you should mistake me. Science is a double-edged weapon. So only in the hands of someone who knows to deal with it, it is a good weapon. So more than this, I need not tell. So 8 out of 10 of you would have understood what I was trying to say. So that was one thing. And next, one more thing. Yes, these two. That is reducing your number of times to convey the information can be used by what I said, finding out the next of kin. For example, explaining to the family, they can do, because all that internal politics in the family and all, they can manage. Okay, so that is one. And then you give the assurance to the patient that they can come back to you. See, many times they'll be scared. Oh, if I come and ask you 4 times, will you get angry? No, if you tell in the beginning itself that yes, they can come back with their queries and doubts, so that they won't feel offended. Okay, he or she has told me that I can go back. So what you can tell them, please write down all your queries and come. Then we can go through it. So these are few things to reduce the number of consultations. But we will need few. One setting and all will not happen. And in very well, Mukta mentioned about these stages, no, like denial to bargaining. Any way to go, and then it will start. It can start from behind to front also. No. I was thinking like this. Now because see, it is not only you and the patient. Outside world will be giving so much information for them. So in that also, again, how much to take? So some things we can say, please, any queries you have, please come back to us so that we are willing to give as much information. And there you can also use the support of psychologists and things like that. Whatever facilities are there in your hospital setup or in your hands, what are the facilities and services that you have, you can tell them that, see, we can help you in these ways also. There were no more queries or things in the chat. I think, they were, that's it. The only what was there before. Anybody else wants to ask, or we will go with the case presentation? And then I think we'll go with the case presentation and then have the discussion of that case and any other queries also. So I think we'll go with that.
So today's case presenter is Dr. Wilbur Manas. I welcome, sir. Over to you.
Hello.
Yes, sir, you are audible.
Hello, ma'am. Can you hear me?
Yes, we can hear you. You go ahead.
Okay. Good evening, everyone. I'm Wilbur Manas. I'm a family physician based in Shillong, Meghalaya. So I have the case that I want to present before you this evening is I had this patient, patient R, we can say. His name started with R. 97-year-old male. Progressive fragility of old age with a few pressure sores on his sacral region and on both his heels. So about 6 weeks he had these sores, and I had not met him at this stage. And then when the last 2 weeks, when it started oozing and they started having a little bit of problems managing him, they had asked me to come and see him. So I do home visits. So I went to see him at home and try to understand what the case is. The next slide, please. So over the last 6 weeks, he has gradually been growing weaker over the last 3 months. And then last 6 weeks, his appetite has decreased and he just wants to stay in bed. Does not want to go to the hospital, and his children have been asking him to go, but he doesn't want to go. And 97 years, he's been a very active farmer all his life. Now he says he just wants to die at home. He has no complaints of pain, but he just wants to be in his bed because of weakness. He has been a couple of times to the hospital, but he has never been diagnosed, or nothing has ever been found. He has no chronic diseases, no diabetes, nothing. He's not on any medication at all. However, he is acutely aware of his surroundings and the people in his room. He's talking to them, recognizing most of them. He developed a bed sore over the sacral area and also both the heels over the last 2 weeks, which hurt when he moves. So onset 6 weeks, provocation factor, minimal movement, just a little bit of movement also causes pain. And rest, analgesics, regular wound dressing has been done to take care of those wounds. Continuous aching type of pain, no radiation, very moderate. It looks like he does not complain too much except when he has to move and when they have to change him. And it's all the time. It's not limited to any morning or evening or night or whatever. Sometimes the sleep is disturbed due to pain, and he had 1 or 2 days of fever a few days ago. Oral intake, very little. Now they are giving him only oats, and bowel and bladder habits are normal. He doesn't go to the toilet anymore, but they are taking care of him in bed. Next slide, please. So he is conscious, oriented, normal temperature, pulse 75, gradually coming down. Respiration normal, no heavy breathing. BP 120/70. All the systems are within normal limits, except he's been losing weight over the last couple of months. Yeah, the only issue that he has is pressure sores. Like I said earlier, the one on his sacrum is a little bit of slough is there and a little bit of smell. So also on the left heel and the right heel, about the same size, just on the points where he keeps his feet on the bed. So 2 by 3 centimeters each, and they look about the same as the one on the sacrum. Okay, next slide. Sangeet, next slide, please. So hemoglobin 10, TC 34,000, P 80, leukocytes 18%, E 2%, platelets 1.6, creat 0.9, serum sodium 134, potassium 4 mg. So basically all his routine, his investigations also were mostly normal. So we just had to control a little bit of that fever, which he had for a couple of days. A very small dose of paracetamol, only 125. We gave him syrup because he was not taking solids anymore. And then also lactulose for his, so that he could void normally. He was given an air bed and position change twice a day, wound dressing twice a day, cleaning and dressing. We did metronidazole irrigation first, and then later on we also used mupirocin. Mupirocin seemed to dry up the wounds very quickly, and he was much more happy with his drier wounds. And all of this was taught to his children so that they were handling everything every day. Yeah, and then we kept the wound closed. Next slide. So psychosocial aspects, 97-year-old married man living with his 64-year-old wife, with his youngest daughter, who is his 12th child from 3 wives who, after the first one died, then he got married again, she died, then he got married again. And so the 64-year-old one is his 3rd wife, and he has 12 children. And they're living in the same house with his youngest daughter. His children and grandchildren all stay in the same village and constantly in his house. So he was a farmer, and they do not live a lavish life, but he has no financial concerns, as his children are providing for him and his wife, and they are also ready to shift him to hospital if necessary. However, he has specifically instructed them not to take him to hospital. He's and members of his church frequently visit him, and he has no debts, so nothing. Has a life with few regrets. Yeah. Next slide. Sangeet, next slide. So main concerns are pressure sores and gradual weakening and the refusal to be hospitalized. Okay. Next slide. So summary, 97-year-old man who has gradually weakened to being confined to his bed, developed pressure on his back and both his heels. His pain is confined to his source, and he has no chronic diseases. Next slide. Yeah. So a few discussion points. Is there any need to shift him to hospital? What other aspects should be explored to provide him more optimum comfort, and what aspects must be dealt with to help his family through this time. Thank you.
Thank you, Dr. Wilbur. If you want to take us through your queries, what are your opinion, and then we can ask the rest also what would they want, and Mukta will add her information. What do you think? Is
Yes.
there a need to shift him to hospital? Will you shift him?
If patient doesn't
Ma'am,
want,
it's not
if patient's
clear.
wish is
I
not to
can't,
shift him to hospital, better treat him at home.
That's all. That's why I'm asking. These like all your opinions and things. What is that you will do? That it's for discussion. So basically, yes, very good that you said you're following patient's wish, autonomy, and doing that. And now, what having had these two sessions on communication, how are you going to explain this to the rest? He has 12 children. Will all 12 children be alike? So what will you do in those situations? Go ahead.
Yes, ma'am. Ma'am, so he's staying with his youngest daughter. So she has kind of taken the, she and her husband have taken the primary role of taking care of him and also handling all these queries. Yeah.
So was she in agreement with her father's wish?
Yes, ma'am. Actually, they also, because they recognize that he has no pain as such, which have since dried up and they're much better. So they they're not really looking to take him to hospital.
Okay. So then, in that case, what other aspects should be explored to provide him optimum comfort? What are things that you think can be done better?
So,
for example, his bed sore management, what all has been done? Have you explained like caregiver awareness, like are the caregivers aware? You typically mention that the site of the wound are in the pressure points. So alleviating the pressure points.
Yes, ma'am.
Someone has mentioned about antibiotics. We'll come to that later. Main thing is that why do pressure sores happen? And you said the point that it is the pressure point. So raising awareness, we will have one session on that itself. But just to say is, have you taught or told them anything about treating those pressure sores? Because his pain is only there.
Yes.
So what has been done for that?
Ma'am, so I've taught the sons to handle that. They are doing dressing twice a day, and they are changing his position as well regularly to sleep on his side and then on his back. But he's not willing to sleep like for too long on his side. But he's okay, maybe for an hour or two, and then he wants to come back. And also elevating. Yes.
Go ahead. Yeah, what else? Like rotating, changing position. Something more you can do.
Ma'am, and they also bought him an air mattress. So
See, air mattress is not the treatment for pressure. So as I said, we will have an entire session for that. But it helps. That even if someone is on air mattress, you have to change position. But that air mattress or whatever, any of that will help it will help in hastening healing.
Yes.
On top of that, we have to do, and the thing is that changing position every 2 hours just by putting some pillows on the other side. You need not get somebody else also. Just like if you just place pillows on the entire one side and give the patient, and some good ventilation, everything, those type of things will be good. And someone, Mukta, you just add on what you want to, and there was some thing in the chat box. I will check that also.
Yes, ma'am. Yeah. So yeah, first of all, like I think we've already agreed to this, that when we say the first thing that you put here, is there a need to shift him to hospital? What actually came to my mind was another question: whose need is it to shift him to the hospital? Many a times we ignore the patient's need, and the family also does it many a times, and that is what it's also related to your third question of what aspects must be dealt with to help his family through this time. Is firstly to help them realize that uh, it's not his need to shift to the hospital and to undergo all of that, simply to see, there are times that I've had to have had this a little confrontative interactions with some of the family members of patients that I was dealing with, where I had to let them know, of course gently, that they were being selfish in trying to shift the patient to the hospital or whatever, because they were uncomfortable with what was happening to him, but he did not wish for it. He wished to stay at home, and he knew that he was going to pass away, and he was okay with it. So it's not an easy conversation to have with families, but sometimes we need to. When it comes to optimum comfort, there is also this. I mean, from my side of the field, I'd say that emotional comfort is also going to be important. So let's say, for example, we see that people around are only talking about his health when they're talking to him, or they're only, whenever they talk to him, it's only to ask if he's feeling any pain or is he comfortable or whatever, and they're not having any general chit chat with him. Nobody is telling him stuff other than stuff related to his health. Now this is something that we can definitely change. These are minor changes, and that can really help elevate the patient's mood, and everybody's mood. Basically everybody's emotional health will be improved in the family if we make these small changes. And if we all agree that, yeah, that's the focus, the aim is to make sure that he is satisfied and happy in the last days of his life. From a palliative psychologist's point of view, actually, your patient seems to be a very ideal patient to me in terms of psychological health, where, given all other considerations, that he has had a very fruitful life and all of that, and a big family which is there around, no unfinished business, no financial, somebody who is at peace with the fact that, okay, I've lived 97 years and I'm okay with, I just want to be at home and pass away amongst my loved ones. That's a very psychologically well-adjusted person, I would say. And I don't really see any need for any particular psychological, psychosocial intervention. So to say only that one thing which I mentioned, that the environment at home, if it is being very illness-centered, health-centered, we can definitely make minor changes to it.
Thank you,
What
Mukta.
about
Only other
pain
thing,
component? It's
Ah,
better
see,
to treat that so that
yes,
family
yes, go ahead.
members will be little bit satisfied about that. When patient is
So
little comfortable
that's where
without pain,
healing. No, that's what. See, the pain. Sangeet, can we come out of the
then it's
screen,
more
Sangeet?
easier for us to handle the family members.
Exactly. So that is why I was trying to say about treating the pressure source, because his problem was mainly the pressure source. Once you treat the pressure source, it will be more helpful. And the thing is that educating and antibiotics, somebody has mentioned, generally for pressure source, antibiotics is not the first line. There are, as I said, no, you will have an entire session for pressure source in which it will be dealt with in great detail. Only if you do a swab and find out there is, that's what you have to stage the pressure sore and then see how it is. All that you do and then treat appropriately. Alleviating the pressure is the first important thing. So treating here, as Dr. Pushpa mentioned, treating the pressure sore will alleviate his pain also. Yes, definitely. Pain relief is the important thing there, which has to be done along with treating of the pressure sore. And one more thing, what I just wanted to add on was, we have to tell the family, see, the patient wants to be at home. They have to be told what are the stages, what can happen from now on till his death. You have to tell them. So we will have all those things in end of life care also. So we have to inform, see, because as Mukta said, no, the family are scared to see and manage that at home. So they have a fear that it cannot be managed at home. So that is why they may ask you to shift. So in those stages, you may have to slowly tell them what all can happen, asking them to get in touch with you regularly. You can do, as Dr. Wilber said, he may see the patient if required, like if he's seeing once a month now, if his condition deteriorates, then he can see him weekly once, or depending on the situation, then speak to them over the phone. In today's world, you can do a video call and see his condition and explain to them. You have to explain to them from now on till his death what all can happen based on the situation. If it is only pressure sore, treating the pressure sore might help it. Or if, as I said, no, in end of life care, we'll deal more. There are stages for that also. So based on that, knowing how his condition is. So now main aim is to treat the pressure sore. By treating the pressure sore, giving adequate pain relief also. So once the sore is dealt well, because from what he presented, there is no pain otherwise, and only pain is with the pressure sore on movement. Is that right, Dr. Wilber?
Yes, ma'am.
So that is what. So you give some, according to the ladder, you can go for mild to moderate pain relief, whatever is required. He is not having any other comorbidities. So based on that, you start treating the pain with step 1 and 2 analgesics, what is appropriate for him. And see, with being a farmer, I think his tolerance level, everything, you assess and treat him. Assess the pain treatment regularly. You start something for him and assess him in 2 to 4 days over a phone call, and manage his pain well, treat his pressure sore also. So if you do both pain relief and sore healing, already, as he said, no, they've got air mattress, so everything, and then you can put just, if nothing is there, also a glove. All that will be dealt with in the session. You can just fill water in a glove and make that as cushion and put it under his heels. So there are so many ways of, see, in Pallium and in palliative care, we teach patients to get things made from what they have at home. So that's what, that wound management session, you will see. You can do so many things with stuff what is available at home. That's what we teach. Not expensive. Best, don't think that because it's done from things at home, it's not, it is in par to whatever you get from outside, or even better off. So those, like treating or managing his pain and pressure ulcer has to be done very importantly, and because that is his main concern. And then the other point is explaining to them what can happen, and as I said, that will be dealt with in great detail in end of life. It is our duty to tell them. That is one of the reasons they may say shift him to hospital.
Yeah.
So those are things we have to tell. And we can explain, and Dr. Wilbur can give assurance to them that he is always approachable on the phone, and he will make the home visit as and when required. Do you have a team, or is it just you doing the home visit? Do you have a nurse, someone with you who can do the visit?
I have a nurse, ma'am.
See, so in those, even for pain, and that's why we conduct these same type of course for nurses also. So I do tell them, see, the doctor, that is why the nurse, doctor, and the social worker are a very good team if you have these three. So the doctor can do the visit, start things, and then the nurse can go make the reassessment. So two things are there. Someone is visiting the patient, so you can see in reality whether the sore is getting better, the patient is feeling better. So reassessment can be done by them. And then accordingly you can. And then on top of that, they can contact you over the phone also.
Yes, ma'am.
So that is, so all these together will help in a methodical way, and also satisfying for the patient also, because it's not that nobody is seeing. Someone seeing them is a big thing. And then another thing, as Mukta and Wilbur were telling you, see, involving, don't make them be in one room and no one goes into that room. Those are all isolating when they become immobile. So some part of the day, if they can be put on a wheelchair, they can come to the room where the others sit and eat or talk, or you can go sit there and speak to them. That isolation, they have a feeling that, oh, they are no more useful. So everyone has started discarding them. All these things will, when someone is restricted to a room, they themselves feel, oh, my life is all inside one room and four walls. So show them daylight. There are so many things which can be done very easily. This day-night concept itself may go off if they are in a room where there are no windows.
Yeah.
So there are many, many things which can be done and can be explained to the family also. Dr. Pushpa, have I answered all your queries?
Yes, ma'am.
Okay. Anything in
I'll tell you
anybody else?
something.
Go ahead.
I'll tell you something, small thing. My
Hmm.
sister was terminally ill. She was almost for 3 months. She was conscious, and all other things were getting managed. I was away from her. So I used to send her regularly some song because she used to love music. So that is just the way during my whatever busy schedule I had, out of that I used to take time for her. More than talking, she used to love this. She used to wait for my this, all such clippings. So such small things we can advise to families.
Exactly. See what the patient likes. Exactly. Again, patient's best interest, we keep telling. And it may not be the same. So you have to see what. Thank you for sharing these type of things. What is that? So making their quality of life better.
Yeah, Radha ma'am, I wanted to add just one thing.
Go ahead.
Just adding on to what doctor just said. I can definitely spot two major strengths here, which can be used to improve the quality of life. One is the spiritual belief system that the patient has, and secondly, that he has quite a big family and they all stay in the same village and they're around. So these are two things which can definitely make a huge difference.
Yes, definitely. Thank you, Mukta. Sharing. See, a respite care and all we do for people who has only one carer or something like that. I mean, this person having so many children and all willing to help, and see, so they can all share and help him. Okay, so burden is shared. And next, his strong spiritual background. There are extensive studies which have shown, all of you can search and see spirituality. They've said in all those studies, what they've found is someone who has a strong spiritual background deals with palliative care situations much, much better than. And there is a big difference between spirituality and religion. It is not the same. So that also has to be understood. And so that those are the two strong things. Generally, we say like best of both worlds, having a big family and being aware or having a good, see, this patient has got Dr. Wilbur from medical or scientific point of view, and he's got the family. So he has got both. So he has got best of both worlds. So this is really, as Mukta said, no, there's not much of like our support could be minimal. If we tap these two, he will get the best. Thank you, Mukta.
Thank you.
Thank you very much for taking us through both these days, and because communication is a very, very important thing. And in depth we have gone. Okay, so big thank you to you, and thank you, Dr. Wilbur, also. And we had another case last session also. Thank you to both of you for bringing up these two cases, because only these cases bring up more discussion, and helpful, because everyone gets to know various things which all of us come across. And I hand it over to you, Sangeet.
Thank you, ma'am. Thank you, Ms. Mukta, for the wonderful session. Thank you, Radha ma'am, for facilitating the session. Thank you, Dr. Wilbur, for the case presentation. Thank you all for participating in the session and making more interactive. Thank you. Let's see you in the next session. Bye.
Thank you, ma'am.
Thank you, everybody.